Hello, my name is Linda Steingold, and I'm the Director of Dermatology Clinical Research at Henry Ford Health in Detroit, Michigan. And today I'm going to discuss the comparison of risankizumab and apremilast for the treatment of adult patients with moderate plaque psoriasis who are eligible for systemic therapy. These are results from a randomized, open-label, assessor-blinded Phase 4 IMMpulse study. These are the authors as well as the relevant disclosures. Risankizumab is a safe and effective humanized IgG1 monoclonal antibody which inhibits IL-23 and is approved to treat moderate to severe plaque psoriasis. It's also approved for psoriatic arthritis and moderate to severe Crohn's disease. It's demonstrated superior efficacy to other psoriasis treatments, including adalimumab, ustekinumab, and secukinumab. This is the first study comparing the efficacy and safety of a biologic, in this case risankizumab, with apremilast in systemic eligible adult patients with moderate plaque psoriasis. This is a Phase 4 randomized, open-label, assessor-blinded study in systemic eligible moderate plaque psoriasis patient. The study consisted of two phases. In the first, period A, which was 16 weeks, patients were randomized 1:2 to receive either risankizumab or apremilast, and the co-primary endpoints were PASI 90 and static physician's global assessment of clear or almost clear, or 0 or 1. In the second phase, period B, at week 16, all apremilast patients were re-randomized 1:1 to either continue on apremilast or transition to risankizumab. The primary endpoint was the PASI 90 in patients not achieving a PASI 75 with apremilast at week 16. Additionally, in addition to the pre-specified efficacy endpoints, there were other health-related quality of life, work productivity, and treatment satisfaction endpoints. In period A, 56% and 75% of risankizumab patients achieved the co-primary endpoints of PASI 90 and SPGA 0 or 1 respectively, compared to 5% and 18% of apremilast patients. Additionally, 34% of risankizumab patients achieved a PASI 100 at week 16, compared with 2% of apremilast patients. In period B, looking specifically at patients not achieving a PASI 75 at week 16 with apremilast, 72% of patients who switched to risankizumab achieved a PASI 90 at week 52, compared with 3% of those who continued on apremilast. In terms of complete skin clearance, more than 50% of patients achieved a PASI 100 after switching to risankizumab, compared to 1% of those that continued on apremilast. For the health-related quality of life, risankizumab demonstrated superior psoriasis symptom scale and DLQI results compared to apremilast in both periods A and B. According to the TSQM-9, risankizumab patients achieved higher scores across all three domains of satisfaction with effectiveness, with convenience, and global satisfaction in both periods A and B. The safety profile for risankizumab was consistent with previously reported studies. It was well tolerated with no new safety signals identified. Diarrhea, nausea, and headache were the most frequent reported AEs among the apremilast-treated patients, while COVID-19 was the most frequent AE for the risankizumab patients. During period A, 6.8% of apremilast-treated patients discontinued treatment due to an adverse event, while no patients discontinued in the risankizumab group due to an adverse event. Comparing risankizumab with apremilast, this Phase 4 study demonstrated superior efficacy, improved health-related quality of life, and higher treatment satisfaction in systemic eligible moderate plaque psoriasis patients. High rates of skin clearance were observed with risankizumab. Safety observations were consistent with previous trials, and a higher proportion of apremilast patients discontinued treatment in the first 16 weeks of therapy, with high frequencies of nausea and diarrhea. In terms of study limitations, the open-label design was addressed in part by blinded efficacy assessors at all participating sites. Although there was nominal significance observed across a number of endpoints comparing risankizumab with apremilast, besides the primary and the ranked secondary endpoints, all other comparisons were performed without adjusting for multiplicity. In conclusion, these results show that the risankizumab group performed with a higher rate of clinical response and a favorable safety and tolerability result compared with apremilast. Improved patient-reported outcomes measuring health-related quality of life and treatment satisfaction support the favorability of risankizumab relative to apremilast in systemic eligible moderate plaque psoriasis patients. These are my co-authors who participated in this publication. Thank you very much.